Hello, this is Dr. Ed Kim from the Department of Surgery at UCSF and VA San Francisco, and this is the first PowerPoint podcast on our module on the introduction to the care of the post-operative patient. And in this podcast, we're going to talk specifically about the physiologic effects of surgery. And the goals and objectives are to compare and contrast the care of medical patient as opposed to surgical inpatients, and to describe the common physiologic stresses created by surgical intervention, and explain how postoperative complications can occur due to these physiologic changes. For the typical patient on the medical service, they usually present with a problem that requires a diagnosis, and they're managed medically to recovery and better health. In contrast, the surgical patient can present either acutely ill with a problem, or for an elective problem, they may actually be fine from an overall health standpoint. And then the operation itself, because it is invasive, creates additional stresses. So they actually get worse physiologically. And then in the postoperative period, they are cared for to gradually improve in their recovery back to baseline or to a better state than baseline if they presented with an acute problem. So you can see the post-surgical patient and the surgeon as a hospitalist that takes care of this patient. And this care usually occurs in the form of supportive care that includes pain control, fluid resuscitation, as well as wound care. So this slide shows you some of the things that happen from a physiologic standpoint following an operation. So you must think of surgery as a type of trauma or one that creates a systemic inflammatory response or process. Obviously, the magnitude of the operation as well as what the preoperative diagnosis is will affect the degree and the extent of these type of changes. So now we're going to go over the different individual systems and what actually can often happen. So starting out with the neurologic system, what usually affects the neurologic system are pain related to the incision and the procedure itself, the medications that are used to treat the pain, as well as anxiety and other factors can further cause additional stressor. General anesthesia itself can have effect, and then the specific operations that involve the carotid artery as well as bypass can actually also cause problems in the post-op period with regard to the neurologic status. And we've also come to learn that pre-existing cognitive deficits, and this is especially true for our elderly patients in the VA, can also be significantly worsened or exacerbated following general anesthesia and the stresses of an operation. And so the complications that we're most concerned about or most commonly seen in the postoperative period from a neurologic standpoint is usually pain that may not be adequately controlled, and also a postoperative delirium, particularly in our elderly, again, that's related to all the stresses of the operation and the medical management following an operation. The most feared and unfortunately not that common are acute strokes and also respiratory depression and failure related to oversedation. So moving on to the pulmonary system, usually people have problems from a pulmonary standpoint because again it's related to the pain, the incisional pain, particularly with thoracic operations with a thoracotomy incisions or a subcostal incisions in the abdomen can cause significant pain that makes it very difficult for our patients to take deep breaths, and this can cause problems with atelectasis and pneumonia. Endotracheal intubation also irritates and paralyzes the cilia along the trachea and the airways temporarily, and this can also cause problems. And of course, this is affected by pre-existing comorbidities of the patient. So patients with a COPD or history of congestive heart failures are at greater risk for having pulmonary complications. Most common complications include atelectasis, which is relatively benign. Pulmonary edema can occur with volume overload, but the most feared ones are pulmonary embolism as well as aspiration pneumonia. From a cardiac standpoint, the cardiac system is stressed through the pro-inflammatory states, which can encourage plaque rupture, as well as increased sympathetic tone, which can cause tachycardia and increased stress on the heart. There's additionally fluid shifts that can result in arrhythmias and electrolyte abnormalities, which can also contribute to the similar problems. Pre-op comorbidities that must be considered as risk factors are pre-existing arrhythmias, known history of coronary artery disease, which is common among vascular patients, CHF, and then the use of beta blockers, which we have to be careful to make sure that they are continued on beta blockers in the postoperative period. Complications that are most commonly seen are sinus tachycardia related to a variety of factors. Atrial fibrillation can be seen particularly in patients who've had thoracic or cardiac procedures. And the most feared are obviously acute myocardial infarctions or severe CHF exacerbations. From a GI standpoint, which you will see a lot of because you are going to be on general surgery services, the mechanism is that intra-abdominal inflammation, use of opioids can cause significant problems with the motility and the enteric nervous system. Antibiotics can also result in problems with C. diff colitis, and you can have mechanical problems from the operation itself causing obstruction. And then an additional factor that we always have to consider from a GI standpoint is a presence of liver disease, particularly cirrhosis, that could make the patient a much higher risk with regard to development of complications. The most common complication, obviously, is a post-op ileus, in which the small intestine and the large intestines may not work very well in the initial days following the operation, resulting in nausea, vomiting, and a lot of discomfort. The most feared are anastomotic leakage in cases where their bowel has been stapled or sewn together after resection of a segment, as well as liver failure in patients who have cirrhosis and undergo hepatectomies. And then another is an early post-op bowel obstruction, which can be a significant problem if it's related to a mechanical problem. And by mechanical, I mean that somehow there's kink area of the bowel or internal hernias of sort that can really cause major problems in the post-op period. Fluid, electrolytes, and nutrition. Again, it's a systemic inflammatory problem that results in leaky capillaries throughout the entire body, and poor pre-op nutritional status can cause problems, and liver regeneration for patients with liver hepatectomies is also a factor. So common complications are dehydration, pre-renal states, and even acute kidney injury, as well as edema. The most feared ones that can cause severe or cause death would be something like hyperkalemia related to acute kidney injury, as well as not being careful with regard to IV fluids or monitoring of the electrolytes, and poor wound healing that can occur related to poor nutrition, and this can contribute to anastomotic leaks and fascial dehiscence of the abdominal wall closure. Lastly, Hem ID. Things that cause problems from infectious problems are things like Foley catheter, central lines that can cause line infections and urinary tract infection. Aspiration, poor mobilization can cause pneumonias. Long contaminated operations usually contribute to wound infections. And then if the surgeon has been sloppy or the patient's tissues are very poor, you can have poor hemostasis, which can result in acute post-op bleeding. And then use of anticoagulation with sub-Q heparin or enoxaparin, and often combined with toradol NSAIDs, can also result in post-op bleeding if the hemostasis is not perfect. So complications that result from this, as I mentioned before, the most common ones are wound infections for colorectal operations and other gastrointestinal operation. Pneumonia can occur as well, and urinary tract infections also are something to be considered. The most feared would be acute post-op bleeding, which would require a return trip to the operating room, as well as hematomas, which may not require a return to an operation, early return to the operating room, but can cause chronic issues down the line. So in summary, surgery is a form of stress that can affect all the systems, and it depends on how large the operation is. And post-op care is essentially supporting the patients as they reestablish their homeostasis in all the different systems. You will see different styles. There will be some people who are more hands-on in terms of trying to manage every bit of the physiologic changes. Others are a little bit more hands-off, meaning they kind of let the patient get better on their own, and I think you'll see a couple of different styles. And in addition to being supportive, the other key is that we are vigilantly watching for a set of specific complications that are commonly seen and those that are the most devastating. So I want you to recognize that as surgeons, we are essentially hospitalists in the post-operative setting, taking care of our patients, providing supportive care, and being aware of potential complication. And I'd like to say that we take great pride in the fact that we not only provide intervention, invasive intervention for our patients, but that we also take care of their medical and post-operative physiologic issues after the operation as well. And so I think you'll find that there is a significant culture and philosophy of ownership of our patient and all of their problems in the post-op period. Thank you for listening, and there will be an associated classroom activities in which we go over specifics of the physiologic changes and how we manage each of them, as well as cases that will illustrate the complications that can occur when they're not managed properly or when the patient is overwhelmed due to multiple factors such as the magnitude of the operation as well as pre-existing comorbid conditions.